So we are back with a newer video this Saturday, and the drug that we'll be discussing this week will be Amphotericin B in dermatology. Now we have gone through all the major antifungal drugs in the past. We have discussed the azole classes, including itraconazole, ketoconazole, fluconazole, and other azoles. We have also discussed terbinafine, and we have discussed griseofulvin. So we have covered the major oral drugs, okay, the oral antifungal drugs in dermatology that we routinely use in our practice. Now, last week we discussed the classification of antifungal drugs so that it gave us a bit of understanding regarding their mechanism of action and regarding their particular spectrum of disease activity. Not all antifungal drugs are active against all different kind of fungus. Okay, you have some drugs which are more active against the capsulated forms. You have antifungals which are more active against the dimorphic fungi, or some which are more better suited for areas which are rich in sebum or areas which are rich in sweat. So we need to differentiate what drug are we going to use depending on the most common causative organism for a particular disease, the area which is involved in that particular disease, and various other factors which we have to keep in mind before going forward with a particular protocol to be initiated as for the treatment of fungal diseases. Now, the point for discussing amphotericin B today is because amphotericin B doesn't have a oral preparation. Okay, it is not water soluble. It is a water insoluble molecule. That's why we have the lipid soluble or the lipid formulations of amphotericin B. And because it's not water soluble, the absorption is not that great from oral standpoint of view. It is available as of now only as parenteral presentation or a parenteral or an IV drug, and we have to formulate it. I mean, this is the only drug which we routinely use that requires sonication before we can administer it to the patient, and that makes it a very special drug. Now, before discussing amphotericin B, we just have to keep in mind few important points regarding amphotericin B. One is that it is a very good antifungal agent. So, first point is a very good antifungal agent. The other point is that it is an IV preparation, so no oral preparation. There are few articles which mention topical preparations, but the efficacy is not that good. It's better to prepare it IV. The same IV drug can sometimes be used as an intralesional treatment also. You inject the same formulation or a different concentration of the same formulation directly inside the lesion if you want to treat. But always remember that amphotericin B is a parenteral drug. Okay, the drug is not oral, so we have to keep that in mind. And rest assured, after this video, it will tell us everything we as a dermatologist need to know about amphotericin B and its usage in skin fungal infections. Majorly, the usage is for deeper fungal infections like mucormycosis, aspergillosis, candidiasis, invasive candidiasis, and a good chunk is used by leishmaniasis and majorly visceral leishmaniasis. So we'll discuss everything in this presentation. Without further ado, let's start with our discussion on amphotericin B in dermatology. Now, in last week's video, we have discussed that amphotericin B is a macrolide polyene. So macrolide comes from the antibiotic class, and polyene means poly means multiple, enes means double bond. So the structure of amphotericin B has a lot of double bonds. Okay, that's why it's a polyene. It has a broad spectrum of activity, but that mainly includes molds, yeast, and also Leishmania protozoa. So this is not a fungus; it's a protozoa. Okay, it's a protozoa, and because of that, the spectrum of activity is very broad for amphotericin B. It acts against fungus, it acts against protozoa. There are other very isolated case reports available for different areas in which amphotericin B has been used, and that is because of its unique mechanism of forming pores in the cell membrane. We'll discuss that when we'll be discussing the mechanism of action. Now, amphotericin B initially was formulated as a deoxycholate formulation. Okay, so more of a cholesterol salt or cholesterol based formulation of amphotericin B, and in short, it is known as DAMB, DAMB. It was formulated in 1950s for invasive fungal infections, but because of intense nephrotoxicity and there was other toxicity also, patient was not able to tolerate well. Uh, there was issues with hypokalemia, hypomagnesemia. So because of this, the nephrotoxicity, the liposomal amphotericin B was formulated. So in what happens is, if you have a deoxycholate amphotericin B, in liposomal amphotericin B, it is encapsulated in a lipid bilamellar structure. We'll discuss that in the next slide, don't worry. So in a lipid bilamellar structure, and then it forms the liposomal amphotericin B. The liposomal amphotericin B. Now, liposomal amphotericin B has similar efficacy. It's around about the same efficacy, but the toxicity is markedly reduced and tolerability is markedly improved. Okay, so efficacy is same, but toxicity is less. And as we have already discussed, it's an IV preparation only, parenteral preparation only. Now, this is the structure of amphotericin B, which I was talking about. It's a macrolide polyene. So you can see this number of double bonds. You see there are a lot of double bonds in the structure, and that is why it is known as a poly, which means multiple, ene, multiple double bonds. Now, amphotericin B was isolated from Streptomyces nodosus, which is a filamentous bacteria, by the process of fermentation. By the process of fermentation. It has a heavily double bonded structure and it is amphoteric. Now, what do we mean by amphoteric? Amphoteric means any molecule which can act as a proton donor or a proton acceptor. In detail, we can see any substance which can act as an acid or a base is known to be called as amphoteric. And because of this word amphoteric, we get the word amphotericin. Now, from Streptomyces nodosus, two molecules were isolated, amphotericin A and B, and A was not that efficacious in treating fungal infections. B was much better. B was better. So amphotericin B is a drug that we are more familiar with now. The structure has both lipophilic and hydrophilic areas. Now see that these are so many hydrogen bonds. Now these are not hydrogen bonds, these are hydroxyl bonds. So presence of a lot of hydroxyl bonds make this area polar. And we all know that water is polar. So because of this polarity, this part of amphotericin B likes water and it is known as a hydrophilic. Okay. Now this part has a lot of double bonds and double bonds are non-polar. So these are non-polar and the non-polar things are substances in organic chemistry or carbon-based substances, and that is why this is more lipophilic or lipid loving because lipid is non-polar substance. So half of the molecule is water loving and the second half of the molecule is lipid loving. Okay, so we'll discuss that how this particular structure of amphotericin B translates into its mechanism of action. Now, we have already told you about the liposomal variant of amphotericin B, in which it is encapsulated in a bilamellar structure with same efficacy but decreased toxicity, better tolerability, and we'll discuss how amphotericin B actually acts. Now, before going to amphotericin B, we'll discuss a bit about liposomes. So, liposomes, we can see in this image, it's a bilamellar structure. That means you have two membranes. One membrane is this, second membrane is this. And the individual unit is made by phospholipid. Okay, the individual unit is made by phospholipids. So these are your phospholipid chains. Okay, amphotericin B is somewhat of a same structure. So you can see this pink ball one, this structure. This is amphotericin B, and it is encapsulated in the liposomal membrane. So this is a liposomal amphotericin B. So we will not go into much structures of liposomes, but there are three major substances, the constituents of a liposome. We have the hydrogenated soy, phosphatidylcholine, we have phosphatidylglycerol and cholesterol. So we will not go into much details about the structure. We need not worry about the structure. Just remember that this is a phospholipid. That means an amalgamation of a lipid molecules with a phosphomoiety. Okay, let's move forward. So, liposomal amphotericin B is a parenteral administered drug. That means it's given IV. And because of presence of liposomes, it increases the stability of amphotericin B. So, in the previous diagram, we mentioned that the amphotericin B molecules are incorporated inside the liposomal membrane. So the stability of the stability of amphotericin B substantially increased. Okay, so presence of, or you could say the formulation of amphotericin B as a liposomal molecule makes it more stable. It also enables the active compound to engage with the fungus, the active compound being amphotericin B. Okay, so because of presence of this kind of structure, the liposomal structure, it enables the active compound to get a good engagement with the fungal membrane, leading to a better action. So liposomal amphotericin B, same efficacy, same efficacy, increased tolerability, decreased side effects, increase engagement with the fungal membrane, and increase stability of the active agent. So we have given you 5 advantages of liposomal amphotericin B. So in subsequent slides, whenever I am saying amphotericin B, more often than not, I mean liposomal amphotericin B. Now, amphotericin B has various formulations. We have the initial one, the first one, which is amphotericin B deoxycholate, or ABD, or you also know it as DAM, deoxycholate amphotericin B, also Fungisome. But remember, nowadays Fungisome can also be used by liposomal formulations. So whenever you are administering liposomal, just make sure and write in full form whatever you are administering, whether you're giving the deoxycholate form or whether you're giving the liposomal form. That's very important. No matter, never mention the trade name. Always mention the constituents. So these are rough doses. Of course, doses will change depending on the indication, zero point 0.7 to 1 mg per kg per day. You have ABCD. ABCD is amphotericin B colloidal dispersion. Remember that amphotericin B is not water soluble. You have to disperse them into a media, a non-polar media. And because of that, you create a dispersion of amphotericin B molecule in a substance, and that is known as ABCD, or amphotericin B colloidal dispersion. You can also have amphotericin B as a complex with lipid molecule, then it becomes ABLC, amphotericin B lipid complex. Okay. The fourth is liposomal amphotericin B, or LAMP, which is also known by the name of ambisome. The total drug required is greater than the deoxycholate one. Okay, but the efficacy is same. The side effects are better. Okay. So whenever in subsequent slides, we'll discuss only liposomal amphotericin B if I don't mention it separately. Now, regarding the pharmacology of amphotericin B, it's somewhat interesting. The amphotericin B does not show a linear pharmacokinetics. It shows a non-linear kinetics because the half-life, or the uh, let's say the level of drug in the system, it kind of increases with increasing doses, and the activity kind of depends on the plasma concentration of amphotericin B. So what happens is, let me just show you this graph, and then you'll be able to understand it a bit more easily. The initial concentration rises very rapidly when you're administering amphotericin B. So roughly at around 10-hour junction, you see a decrease in the concentration of amphotericin B. So this 10-hour becomes your first half-life, which is here, 7 to 10 hours. But many articles mention 100 to 153 hours. Now, why is there a discrepancy in these two half-lives? The discrepancy is because the amphotericin B, being a lipid molecule, gets sequestered into body structures like spleen, liver, fatty tissues. Okay, it's lipid soluble. Okay, and when the drug is stopped, the drug starts to get released from these storage areas in the body, and that is why the T half is prolonged. So with subsequent dosages, with repeated dosages, even after there is a rapid decline in the concentrations, you will see that it takes a bit slower time to plateau down, and it remains for as long as you could say 153 hours, 100 to 153 hours. So this kind of redistribution capability is present. Remember, the last time we saw this kind of redistribution capability wasn't clofazimine when we were talking about Hansen's, isn't it? So action may not be dose related, but action depends on the serum level of amphotericin B. The bioavailability is 100% because it's an IV infusion. It's not an oral drug. We have to give it. It is not. It is strictly an IV drug. So the bioavailability is 100%. Now, excretion is seen in 4.5% in urine and 4% in feces, and that this is unchanged amphotericin B. Now, I'm talking about amphotericin B because liposomes are not excreted. So, what happens is the liposomes they they are kind of they dissolve out and they release amphotericin B at the site of action. So intact liposomes are not seen in urine or feces. We see degraded amphotericin B or unchanged amphotericin B, two types, and the unchanged one is measured in the studies, which is 4.5% urine and 4% in feces. The amphotericin B is not removed by hemodialysis because it has a uh, good activity as far as sequestration into cell membranes is concerned. It gets attached inside the cell membrane of the fungus, so it's not easy to remove hemodialysis. Okay, so let's move forward and we'll discuss the mechanism of action of amphotericin B. Now, this diagram we have already seen when we were discussing the individual drugs in the antifungal spectrum. And here we have the polyene antibiotics, which includes amphotericin B and nystatin. So, amphotericin B acts on the cytoplasmic membrane or the cell membrane, okay, here at this level. And I'll show you how it actually acts. So, the mechanism of action of type of amphotericin B in fungal cell membrane is that it has an ergosterol affinity. So what do we mean by that? That means it attaches itself to ergosterol. Now ergosterol comes from a family of cholesterol. Okay. Now cholesterol is also present in mammalian cell membrane, and because of this presence of cholesterol in mammalian cell membrane or human cells, it leads to toxicity. Okay. So let me just clear it out again. Cell membrane has cholesterol. Fungal cell membrane has ergosterol. Human cell membrane has normal cholesterol. Amphotericin B binds to ergosterol with a greater affinity as compared to mammalian cholesterol. That is why you have a fungal specific action. But if it binds to human cell, it causes toxicity. Clear? Now, because of this ergosterol affinity, it gets included inside the cell membrane. And here the cell membrane is of the fungus. It gets incorporated inside the fungal cell membrane. And because of this incorporation of amphotericin B, you have a pore formation. A pore is formed here in the cell membrane, and that leads to cell leakage. Okay, that leads to cell leakage and cell death. Okay. And just to remember that 8 units of ergosterol stabilize 8 units of amphotericin B. And because of this pore formation, there is an exchange of ions. This fungal cell loses a lot of potassium, it loses a lot of magnesium, and there's an influx of hydrogen ions inside the cell. And because of this increasing protons or a decreasing pH of the fungal cell, the cell eventually dies. Okay. Low concentration amphotericin B can lead to potassium leakage through the same micropore formation, and the action of mammalian cholesterol leads to toxicity. So let's discuss how the micropore actually forms. Now, this is the structure of amphotericin B. We have discussed that in the first slide. We have the lipid-loving yellow part, which is the lipophilic part. We have the water-loving blue part, which is the hydrophilic part. And this is phosphatidylcholine in the cell membrane of the fungus. This is from the fungal cell membrane. So this is amphotericin B. Clear? So what happens is you have two different aspects of the amphotericin B molecule. You have the lipid loving and the water loving. So here we can see that this is the cell membrane of the fungus. The yellow ovals are ergosterol. They are ergosterol molecules. Now what happens is that amphotericin B aligns itself such that the lipid-loving part is stabilized by the ergosterol molecules. So here there is stabilization by the ergosterol molecule, and the water-loving part forms the inside of the pore. So you can see that it has created a sort of break inside the cell membrane of the fungus. And we all know the cell membrane are two-layered structure, okay, bilamellar structure. So let's translate the same thing. into a two-layered structure. So here we can see the lipid-loving part of the amphotericin B stabilized by the ergosterol cholesterol in the fungal cell membrane. Same thing happens on both sides. 8 ergosterol will stabilize 8 units of amphotericin B, and this amphotericin B, imagine that in a 3D location. This is a 2D representation, but if you imagine it, a circle is formed. A circle is formed like a cylinder, and the outer wall of the cylinder is lipid loving, which is stabilized by ergosterol. The inner part is water loving, which facilitates the transfer of ions from inside the cell to outside and from outside to inside. Okay, and when this pore is formed, this pore is known as a micropore. So amphotericin B is responsible of forming this kind of multiple pores in the fungal cell membrane. And through this micropore, the potassium ion moves out. The potassium ion moves out. The magnesium ion moves out. And what moves in is the hydrogen ions. So hydrogen ion goes inside the fungal cell, potassium and magnesium goes outside the fungal cell, and because of this change in the ionic structure and increased acidic milieu, acidic environment of the fungal cell, the cell eventually dies. Okay. Now here we will discuss a unique method of toxicity because of amphotericin B in humans. Okay. So we have discussed that amphotericin B is nephrotoxic. Why is it nephrotoxic? The same pores can be formed in renal tubules. And because of these pores in the renal tubules, the potassium ions are lost, the magnesium ions are lost. And because of that, a very important toxicity is hypokalemia. You have to keep the potassium ion and the magnesium ion under your observation when you are giving amphotericin B. Okay, that is how amphotericin B actually causes hypokalemia and hypomagnesemia. It has also other effects on the kidneys, which includes maybe decreasing the glomerular filtration rate and direct drug-induced damage in the renal tubules. But this is the main mechanism why amphotericin B actually causes hypokalemia and hypomagnesemia, and that is why you need to measure the potassium levels and magnesium levels more often. You have to measure it daily while you're giving amphotericin B. If it's the first infusion, you have to measure daily so that you're not pushing your patient towards hypokalemia or hypomagnesemia. Clear? So we have discussed how micropore is formed by amphotericin B and how it causes hypokalemia and hypomagnesemia and nephrotoxicity. Now, how to administer amphotericin B? That is very important. It's a very special drug. Okay, you have to neutralize it. Sorry, you have to dilute it with a sterile water. But this is an older formulation. Usually, what happens is nowadays you just get a vial of amphotericin B. Okay, and most often it is liposomal amphotericin B, which already has the lipid formulations inside, and the normal concentration is roughly 50 milligram per 50 ml. So approximate 1 milligram per ml. So it comes in a sealed bottle and you just have to sonicate it, dilute it and administer it. Okay. So in older days we used to, not we, people used to dilute the powdery form of amphotericin B with sterile water. Okay. In any instance, no saline has to be added to amphotericin B, otherwise it forms a precipitate. So no saline, no normal saline should come in contact with amphotericin B. Okay. So this is the older dilution, but now we have the preformed liposomal vials. And we have to shake vigorously, but now we sonicate, so we need not. So what happens is, so how do you administer? You get a vial of 50 milligram per 50 ml of liposomal amphotericin B and you put it in the sonicator. We'll discuss what do we mean by sonication. And after you have sonicated, you take the required amount from the vial and put it into 5% dextrose. Okay, and you make your desired solution of 1 to 2 milligram per ml solution. You dilute it further and then you administer the required doses which you have calculated as per the weight of the patient and the indication of the patient, and you start the infusion. Now, dextrose has to be neutralized with insulin. We used to use 8 units of insulin to neutralize, but you can go as high as 16 units, depending if a patient is diabetic or not. But you have to neutralize the sugar already present in the dextrose with insulin. 8 units is enough per unit of dextrose. Okay, so you take a vial of 50 milligram per ml, 50 milligram per 50 ml of liposomal amphotericin B, you sonicate it. After sonication, you dilute it with 5% dextrose and start the infusion. The infusion should be over 2 hours. The first infusion might be slower. You can go as slow as till 4 hours. But you cannot, when you're giving it the first time, do not go faster than 2 hours. If the patient has received multiple infusions before, you may increase the infusion duration, decrease the infusion duration till over 60 minutes. Okay, fast infusion, but make sure you are taking care of all the all the potassium and magnesium ions. So the first infusion should go over 120 minutes or over 2 hours. Okay, let's move on. So you have to hydrate the patient very well. It's a good idea to use 1 unit NS. Now here the NS you're giving for hydration, it is not coming into contact with amphotericin B. Remember, if normal saline comes into contact with amphotericin B, it will precipitate. So you don't have to mix these two things together. Pre-medicate using diphenhydramine, hydrocort and acetaminophen, the usual pre-medication that we use. Use a filter of pore size of more than 1 micrometer for deoxycholate version. Now what happens is that deoxycholate, when you're diluting it with sterile water and shaking it vigorously, there might be bigger particles left. So you don't allow the bigger particles to go into circulation. So you have to use a filter. But nowadays, we are using the liposomal formulation which we sonicate before administering. So you don't have those larger particle size. So you don't require a filter. In your ward, whenever amphotericin B is being given, you must have observed that we just sonicate, dilute and give the infusion. We don't use a filter. So nowadays we need not use a filter. Once a dilution has been made, you have to use it within 24 hours. You cannot keep it stored. Okay, you have to use it within 24 hours. So you have hydrated the patient, you have pre-medicated the patient, and now you are ready to give amphotericin B. So what is sonication? Sonication comes from the root word sonic, which means sound. Okay, so you use sound energy to vibrate particles. This is a sonicator machine. Most of the time, the sonication is done by the nursing staff, but whenever amphotericin B is being prepared as a resident, or maybe after that also, you should always see the process how it is being formulated. Okay, you may never know that you might have to sonicate yourself, or after all, it's your patient that you are treating. You should know everything about the process. So whenever next time, whenever amphotericin B is being administered to any of your patients, go and have a look at how the nursing staff does it. Okay, so sonication is done for 45 minutes in a water bath. So this sonicator has a lid. You remove this lid, now you will have a water bath inside, or you will have an empty bath. You fill it with water. You put the liposomal amphotericin B vials inside. You cover it and set it for 45 minutes at 30 degrees Celsius. Okay, below 30 degrees Celsius. And what happens is that sound energy leads to vibration of those vials. So they will vibrate very fast. And what it does is it converts those larger multilamellar vesicles to unilamellar vesicles. That means you will have a lot of clumps of these kind of liposomal vesicles, the aggregation of liposomes, and because of sonication, they will break apart. They will be separated, and it will be easier for us to administer in the IV line. So for all liposomal drugs, you have to sonicate, and most often we use liposomal amphotericin B. So we have to sonicate it first for 45 minutes. So we'll always have to tell the nursing staff that we are going to administer amphotericin B. It is not a start drug. You have to pre-medicate, hydrate. By the time everything is going on, put the amphotericin B for sonication, take it out, administer. Clear? So the acute infusion reaction is a very important reaction for amphotericin B. It usually occurs within the first 5 minutes of starting infusion and can occur within the first 3 hours, usually within the first 5 minutes. It includes fever, chills, rigors, chest pain, dyspnea, abdominal pain, flushing, urticaria. nausea, vomiting, tachycardia, all sorts of infusion reactions. It decreases with subsequent infusion. That means if a person has had a little bit of infusion reaction or little bit of problems with the first infusion of amphotericin B, the subsequent infusion would be better. Okay. So what you should do is you should give a slow test dose to see if the patient is developing an infusion reaction or not. You give the first, you could say, you have prepared the liposomal amphotericin B, you have sonicated it, you have put it into 5% dextrose. You start very, very slow. Let's say 0.5 ml per minute, 0.25 ml per minute infusion. Observe for 5 to 10 minutes. See if the patient's heart rate is okay, if the respiratory rate is okay, if there's no temperature change at least in the next half an hour, there's no breathing problem, there's no pain, there's no itching, rash, nothing is developing, then you can gradually increase to 1 to 2 ml per minute and let it be there. Okay, and let the infusion go on. And you have to titrate the rate of infusion depending on how well your patient is tolerating it. So always a slow test dose is very beneficial when you have to keep into account the acute infusion reaction with amphotericin B. Okay, so not everyone will have amphotericin B, and how to prevent it? Number one, hydrate your patient. Number two, use a slow test dose. Number three, pre-medicate. Number four, observation. Keep observing the patient. It doesn't, you cannot just write on the register that administer amphotericin B and just go about, have your lunch, dinner, or do some other work, or do some important work, do some thesis work. Keep observing your patient, especially if it's the first infusion, and you will detect acute infusion reaction very easily if it happens. Okay, so you have started amphotericin B. You have pre-medicated, hydrated, everything's going on. We'll just discuss what the spectrum of amphotericin B and uses of amphotericin B. Spectrum includes Candida, and we are talking about the invasive candidal infections, the histoplasma, Cryptococcus, blastomycosis, aspergillosis, sporotrichosis. Okay, so these are all deep mycosis. These are all deep mycosis. Okay, or deep fungal infection. We don't use amphotericin B for superficial mycosis. It has dermatophytes are mentioned, but do not use it. We need to have some drug which is acting on deeper mycosis. Let's not create a nuisance by increasing resistance. Okay. Now, Leishmania is important. It's a protozoa, it's not a fungus, in which the amphotericin B has been actually approved for visceral leishmaniasis by WHO. So it becomes a very important indication. So the spectrum includes deep mycosis plus leishmania. Okay, so it's easy to remember. Deep mycosis with leishmania. Deep mycosis includes candida, histoplasma, cryptococcus, blastomyces, aspergillus, sporotrix. Now, the first five are the FDA approved uses. FDA approved uses of aspergillosis. Okay, the first is empirical therapy for febrile neutropenia. Whenever you have a febrile neutropenia or the neutrophil count is low and the patient developing fever, and you have ruled out the bacterial, viral, protozoal causes, and you suspect fungus as the cause of febrile neutropenia, as an empirical therapy, it has been amphotericin B has been approved. For cryptococcal meningitis, especially in HIV positive patients, along with flucytosine, it's actually the first line drug. Aspergillosis after voriconazole, so it becomes a second line drug. Voriconazole is first line, second line is amphotericin B. Invasive candidiasis, second line. Visceral leishmaniasis, it has been actually WHO and FDA approved for visceral leishmaniasis. Other is mucormycosis. We have heard a lot about during the COVID pandemic that aspergillosis, mucormycosis being treated with amphotericin B. So it's another uses. And disseminated and sporotrichosis, disseminated severe sporotrichosis is also another indication where the other antifungal drugs are not showing benefit. So we'll discuss leishmaniasis a little bit in detail. I'm not going into deeper mycosis treatment with amphotericin B in detail because the only the dose the dosages change. And when you have the diagnosis in hand, a biopsy and a culture diagnosis of a deep mycosis in hand, and you wish to start amphotericin B, all you have to take into account is the dosages and the toxicity side effect profile. In visceral in leishmaniasis, it's an alternative therapy, and the other better drugs are miltefosine. Miltefosine. If miltefosine is not working or not available, you may consider liposomal amphotericin B. The combination of liposomal amphotericin B and miltefosine is found to be superior than any of the agent alone. For visceral leishmaniasis, it has been WHO approved. Other uses are HIV-associated leishmaniasis and mucocutaneous leishmaniasis. The dosages are 3 mg per kg for 7 doses. 3 mg per kg per day for 7 doses given on days 1, 2, 3, 4, 5, 14 and 21. The total dose with this regimen comes out to be 21 mg per kg, but you can go as high as 40 to 60 mg per kg per day. That's the limit. So this is the dosage schedule in visceral leishmaniasis. In visceral leishmaniasis, it is 3 mg per kg per day, 7 doses, 1, 2, 3, 4, 5 days, then day 14, then day 21. Clear? With this regimen, roughly 85% of mucosal leishmaniasis and 54% of cutaneous leishmaniasis have shown to have good cure rate as per this article. Where is it? As per this article. If you want to go in detail, go to this article and read. Now, intralesional amphotericin B has also been used. The concentration is 2 mg per ml given every week inside the lesion. The same IV formulation. You prepare it 2 mg per ml. You put it inside the lesion up to 12 weeks and 61.4% show complete cure. So that is another formulation. So for visceral leishmaniasis, I'll repeat 3 mg per kg per day for 1, 2, 3, 4, 5, then day 14, then day 21. Clear? For post-Kala Azar dermal leishmaniasis, it is second line after miltefosine, but combination is found to be superior. The recommended doses for liposomal amphotericin B is 5 mg per kg twice a week for 3 weeks. Total 30 mg per kg per day. So what do we mean by that? Let's say this is 1 week. You give liposomal amphotericin B, skip. Liposomal amphotericin B, skip. 7 days, that makes it 1 week. You repeat it 3 times. Every time you're giving 5 mg per kg. So 5 mg per kg, 5 mg per kg, 10 mg per kg into 3 times 30 mg per kg. Total 30 mg per kg. Okay. So 5 mg per kg 2 times in a week for 3 weeks. Clear? There are other articles which mention lower doses 2.5 mg per kg 2 times a week for 3 weeks or 2.5 mg per kg every third day for 15 days. There are a lot of regimens. There are multiple review articles regarding various dosages for amphotericin B leishmaniasis. If you want to know more about it, I'll give some recommendations in the description. Go through these individual articles, you will find there's so many different type of doses available. Okay, so no particular dose is actually different. You just have to tailor the doses as per your indication or as per your patient profile and side effect profile, how well your patient is tolerating amphotericin B. For cutaneous mucormycosis, now this indication was very popular during COVID. Also, if you have cutaneous mucormycosis, most likely you have a deep-seated infection also. So for mucormycosis, the treatment of choice is amphotericin B plus surgical debridement and control of underlying immunosuppression. You have to control the underlying immunosuppression, surgically debride the tissue, take all the affected necrotic tissue out, and start amphotericin B. Treatment has to be started within 5 days of diagnosis, and recommend duration is till there is clinical or radiological resolution of the lesion, or at least for 6 to 8 weeks. So if the clinical or radiological resolution happens before 6 to 8 weeks, you continue till the 6 to 8 weeks are completed and then stop. The dose for liposomal amphotericin B is 5 to 10 mg per kg per day till there is complete radiological or clinical resolution. Okay. Now, whenever you're treating these kind of infections, deep fungal infections, always keep a person of an infective diseases background with you. in your discussion. Keep discussing. If the patient is entirely under you, you have to keep discussing. If the patient is under infective diseases department, keep talking and keep titrating the doses depending on your patient, the tolerability to amphotericin B. Okay. Now others, I put a star here. By star, I mean that you need to take help from the infective diseases department or internal medicine or maybe any other department which actually specializes in treatment of these kind of deep disseminated fungal infections. Of course, we have where I did my residency, we have given it for aspergillosis, we have given it for histoplasmosis. I think we have given it for mucormycosis also, but I'm not entirely sure. So internal medicine, these have to be kept in the loop, even if you are giving it under your care. So for invasive candidiasis, liposomal amphotericin B 3 mg per kg per day for 2 weeks. Cryptococcal meningitis, invasive aspergillosis, febrile neutropenia fungal in origin. I've written all the doses. These might never be asked in your viva. Don't worry, but it's a good idea to know. If we are discussing amphotericin B, why not know a bit of everything? Okay. So the major use of amphotericin B is in leishmaniasis. We have discussed that in the previous two slides. And in deep fungal infections, you start with 1 mg per kg per day, go as high as 5 mg per kg per day. If you're using the liposomal formulation, if you're using a deoxycholate one, things change a bit. The doses required are less. Okay, so we have discussed the mechanism of action of amphotericin B. We have discussed the uh, usage cases, majorly leishmaniasis, invasive fungal infections. It's easy now to answer most of the questions in Viva. We'll quickly go through the contraindications and adverse effects of amphotericin B, and then we'll finish this presentation. It's already, I think, increased by 40 minutes or so. Plus, because of the cold, I am not able to speak without stopping in between. So let's get this thing done. So regarding the contraindication for amphotericin B, the absolute contraindication is history of any anaphylaxis either to amphotericin B or any of its constituents. Okay, any of its constituents. If there's any history of anaphylaxis to any of these agents, it's an absolute contraindication. It's either you desensitize or you give a lower dose or you keep given the observation or you search for an entirely different drug. Electrolyte imbalance regarding the potassium loss and the magnesium loss, we are told that renal tubular toxicity happens because of amphotericin B. The same mechanism which works on fungal cell membrane works on renal tubules, and there is a loss of potassium and magnesium ion, and there's also an influx of sodium. So hypernatremia can also happen. So hypokalemia, hypomagnesemia is a known side effect. Keep that in mind. Organ dysfunctions like if kidneys are affected, livers are affected, bone marrow toxicity is there, amphotericin B is contraindicated relatively. Edema and hypotension. So I've told you that edema can occur because of hypernatremia or the prolonged kidney damage can lead to edema in geriatric population because they might have an improper renal function. So because of that, amphotericin B, the toxicity increases because the kidney is already damaged and it is getting further damaged by amphotericin B. Okay, so these are the contraindications. 80% of the patients report any infusion reaction or renal toxicity. This was higher when deoxycholate form of amphotericin B was being used. It has decreased with liposomal amphotericin B. Liposomal amphotericin B. Acute infusion reactions is very important. You have to keep that in mind. Remember 4 points. Hydrate, pre-medicate, observation, and what was the last point? Slow infusion. Okay, so 4 points. You hydrate the patient well, you use a slow infusion, you pre-medicate, and you observe the patient well. Nephrotoxicity. It's reversible in the initial stages, but more with the conventional amphotericin B. What do we mean by conventional? It means the oxycolate amphotericin B. So with the older formulation, the nephrotoxicity was higher. With the newer liposomal formulation, the kidney damage is not that much. To prevent it, you use hydration. You hydrate the patient well. Okay. Other things include the rarer forms include the normocytic normochromic anemia. Why would you have anemia? Because prolonged kidney damage or a long-term use of amphotericin B leads to kidney damage, and kidneys are a very important source of erythropoietin. And the function of erythropoietin is to increase the formation of blood. So erythropoietin is decreased, leading to normocytic normochromic anemia over long term. It can also damage the skin, the hearing cells. Why? Because they also work on the potassium influx. Na? Remember your physiology. The cochlear cells works on potassium ions and calcium influxes. So the same mechanism by which it is causing the renal toxicity can also cause ototoxicity. So, drug levels are not that contributory because we need to find out what is the drug level, the site of action. So, if you keep on measuring, it might not show the true picture. Why? Because amphotericin B gets stored in other structures also. Majorly, the structures which are included are, let's say, spleen is a good storage site and liver is a good storage site. And this was more with the deoxycholate amphotericin B. Okay, so you might not see much drug in the system, but the drug can stay for a longer time in the system. So you don't have to monitor by keeping the amphotericin B levels in mind. It's better to do electrolyte panels. You can start with daily and then switch to weekly. There are no issues. Keep hypokalemia in your mind always when your patient is receiving amphotericin B. Clear? And you have to do it every time if there are any clinical signs of hypokalemia. If you see any ECG changes, if you see subduing of ECG or suppression of the T waves or all those hypokalemic changes, so you have to get an ECG whenever the patient complains of any kind of fatigue, chest pain, arrhythmias or palpitations. Get an ECG done as fast as possible. In kidney function tests, if creatinine is more than 3, you should consider stopping the drug. In LFT, if the enzymes are rising, if there's transaminitis, stop the drug. Consider stopping the drug. Now, rapid infusion can cause cardiotoxicity. Remember, you are playing with a drug which causes imbalance in the potassium ion. So keep that in mind that the heart has to be monitored. So either you monitor it with a cardiac monitor attached to the patient or repeated ECGs. Edema and weight gain, you can look at the weekly weight chart, weekly abdominal girth. You can look at the tibial if there's any edema in the lower limb if the patient is mobile. If the patient is bedridden, look at the sacral area for edema. So these are things that will tell you if the patient is storing water and there is nephrotoxicity or kidney damage or increased sodium ions. So key point to keep in mind is take care of the heart, take care of the kidneys with electrolytes and ECGs. Clear? ECG must, electrolytes must. Now, drug interactions with amphotericin B has not been studied properly. So, there are just isolated case reports which the product insert has included. So, I'm discussing it here. Like the anti-neoplastic agents, the potential for kidney toxicity increases. For corticosteroids and corticotropins, the incidence of hypokalemia may increase. Digitalis can also cause hypokalemia. Flucytosine. Remember that flucytosine is given with amphotericin B in many of the cases of cryptococcus in HIV. So it may increase the level of flucytosine by increasing the cellular uptake of flucytosine or impaired renal excretion of flucytosine. So either it will increase the uptake of flucytosine inside the cell or it will impair the renal excretion of flucytosine, leading to toxicity. Azoles. Azoles may induce fungal resistance to amphotericin B. How? We'll discuss in the next slide when we're discussing resistances. Leukocyte transfusions have been shown very rarely to cause acute pulmonary toxicity. It's just a rare interaction, so we have to keep that in mind. Major interaction is with azoles, antineoplastic agents, and steroids, digitalis, okay, and flucytosine if you are giving it together with amphotericin B. Now, it's a pregnancy category B. It's considered somewhat of a safer antifungal agent but it's better to keep amphotericin B for invasive fungal infections or deeper fungal infections, and consider drugs like terbinafine for superficial fungal infections. In the lactation, there are not many studies, not many studies. I tried to find out, but everywhere it is mentioned that it may be excreted in breast milk. Benefit should always outweigh the risk in lactating mothers. So that's what I'm going to tell you. It's pregnancy category B as per the older MD category. The newer is considered safe, but benefit should always outweigh the risk. Okay. Germ resistance. Factors that decrease ergosterol synthesis, which includes your azoles. Now you know. Now you can see how azoles are increasing the fungal resistances. How does it happen? So here you have the amphotericin molecule. This is a very crude diagram of the micropore, and this is the cell membrane. And these are the ergosterol molecules, and it is stabilizing the amphotericin B molecules. So what happens if you give amphotericin B with an azole? The azole will not allow the ergosterol to form, and there will be nothing to stabilize the amphotericin B. And amphotericin B will not be able to make proper micropores, leading to resistances. Now we are clear. So many a times, for example, for histoplasma, we use itraconazole and amphotericin B. Both are recommended by ITSA. But if you use two of these drugs together, remember that azoles are going to decrease the ergosterol synthesis. And when ergosterol is not present, you will not be able to have much molecules to stabilize amphotericin B, leading to resistances. Clear? Synthesis of alternative sterols. Remember that ergosterol is also a type of sterol. If there are other sterols available, they may compete with ergosterol. They may not be able to stabilize it better, and the amphotericin B is not able to act properly, leading to resistances. Other formulations which have been devised for amphotericin B are inhalational, which is usually for maxillary mucormycosis or invasive candidiasis of the nasopharynx. So these are the isolated case report. The nebulous one works the same. Majorly, it's for the nasal. This is for the upper nasal tract. This might be a bit lower down in the lower respiratory tract. Topical regimens have been implicated so that you can apply it, decrease the systemic toxicity, but the efficacy is of course not that good. Oral in the form of nanoparticles or microemulsions are being formulated day by day. There are many articles on this. If you're really interested, you can go deeper and read about them. Remember that the amphotericin B is not an oral molecule. So whenever there is a parenteral molecule, a good parenteral molecule, sorry, a good IV molecule, there's always you want to switch into a oral molecule. The same thing is happening with insulin. You want to have an oral drug, oral insulin. But similarly, for amphotericin B, the oral formulations are being created. Let's see, we might have a good drug in the near future. Other methods of administration include intra-articular, you inject it inside the joints for fungal arthritis, intracavitatory, for example, if you have a lung aspergilloma, you can inject it directly inside the aspergilloma. Inhalation or intralesional for prophylaxis for aspergillosis after bone marrow transplant. This is just one of the isolated case reports that I found some mentioned. Intrathecal means inside the spinal cord, uh, the spinal canals for your cryptococcal meningitis. Okay, so for cryptococcal meningitis, you can use it, or even very invasive aspergillosis or histoplasmosis. So you can use that. But of course, this is outside the purview of dermatology. I just wanted to mention. Let me put a little star here. So with that, the presentation is finished. Let's quickly end this. These are the further reading material. Read the amphotericin B product insert. This article is good if you want to read about use of amphotericin B leishmaniasis. And this is good if you really want to have just a superficial understanding. But trust me, if you have gone through this video in proper detail, you have all the data that you require for amphotericin B regarding the structure, the pharmacology, the pharmacokinetics, the mechanism of action, the spectrum of action, the contraindication, the side effect, the different usages, the drug doses, everything is there in this video. That's all you need to know about amphotericin B. These are further few articles. I will put it in the description, but this video is more than enough that you would like to have. Okay, so with that, we have finished another weekly video. Just this time on Amphotericin B. And I apologize if I'm not able to have a good audio on this because I am down with flu. My throat has just started to recover. So I'm not that, it becomes difficult for me to speak at stretch. And just recovering from fever and flu and backache, and now you have to make a video, it becomes a bit difficult. So if there's any issues, I apologize in advance. Give your comments, write to me on my email, comment below the video, I answer my comments. And with that, we have covered the systemic antifungal drugs. Next week, we'll meet again and we'll discuss topical antifungal drugs. Topical antifungals. And with topical antifungals, we'll finish our this major series sequence of videos on antifungal agents. And if you go through each individual videos, we have covered azoles, we have covered terbinafine, glycifulvin, and now we have covered amphotericin B and the detailed classification of antifungal drugs. If you go through each and individual videos, that's all you're required to know about antifungals as of now. And we'll meet again next week. Adios. Bye bye. Enjoy your weekend. I hope everyone had a safe and good Diwali. Bye bye.